Hello, I'm Manoj Karmakar. Welcome to ISSPS TV. In this upcoming video, Dr. Jan Boublik, a clinical associate professor from the Department of Anesthesiology, Perioperative and Pain Medicine from the Stanford University School of Medicine in California, is going to share with us his insights into focused cardiac ultrasound for the regional anesthesiologist. In case you like any of the videos in this ISSPS TV, don't forget to hit the like and share button. And if you're new to this channel, do remember to subscribe so that you can get regular notifications of any future uploads. Now enjoy the upcoming video.
That was just the topic that I was assigned, and we all know better than to not talk, disapprove. Although it should be for every anesthesiologist, obviously, but we're regional anesthesiologists, a large part of us. So there's a disclosure site, some and expenses. It could, if it stopped doing that. I am a member of the ASA editorial board for diagnostic point of care ultrasound certificate, so that could be perceived as a conflict of interest. But we're going to talk about so just quickly review what FoCUS is, what it isn't, what FoCUS is, why you should be doing it, and go over the basic cardiac views, why they matter, and what options are for regional anesthesiologists where it may be a perceived barrier to embark on cardiac imaging and other limitations. And so my current thoughts on FoCUS and POCUS. So what is point of care ultrasound, right? So it's all over the different journals, and it hardly, one thing we always forget is that the patient is in the center of everything, right? And all the modalities, whether insonate, radiate, labs, all is geared towards that. But it is such a powerful tool, as we know from our regional anesthesia or spinal sonography practice, lung ultrasound, as we just heard. We should never forget that the patient's at the center, not us getting pretty pictures. So it's always called the 21st century stethoscope, and you can perform it any way you need to and answer that clinical question that helps you, evaluate your patient and or manage any hemodynamic or other instabilities with the goal of improving outcomes. And it's sort of is varying skills have different skill sets, but varying learning curves. But limited training can allows you to acquire life-saving skills and make a difference in people's lives. So I borrowed this slide from my good friend Stephen Haskins, because the question is always, is this fiction? No, it's fact that lives in our pockets and, attached to our devices. And while it's always says like this disruptive new technology, right? Maybe it's not all that new, right? If you think back to the FATE exam, which is sort of like a FoCUS transfer echo exam that was developed by Erik Sloth from Denmark, started in 1989 in reality. And so, and I necessarily don't agree with all of the statements here in this beautiful timeline from the recent New England Journal article, but I mean, what I do sort of agree with that the future, like with deep learning algorithms and handheld systems, is here. If not, will even get better. So, and for those, who, to kind of like, I want to say it is going to like change all of the world is if you think that, a person like Eugene Bromwald, who has been doing cardiology for 50 plus years, puts his name onto that, it's time to add this to the physical exam, then, it would behoove all of us to join him in this quest. So, I mean, and the ultrasound, it's a supplemental physical exam. This is from an article that a lot of my good friends wrote on point of view ultrasound anesthesiologist. You can insonate pretty much any part of the body, and you can make, as we will hear through a lot of these different areas today, assess your patient and make meaningful outcomes, and actually, not to treat surrogates, but actually see that your therapies even play out in real life and in real time. So stethoscope versus ultrasound. We'll come back to that a little bit later. But what is FoCUS? So before, there was this great article by Brett Coker and Josh Zimmer on why we need to incorporate FoCUS into our daily practice. And this wasn't just to some cardiac journal, it was an anesthesia analgesia. It is for all non-cardiologist physicians, because with the advent of these handheld ultrasound and the access to them, we really, should be picking up the probe, not just to scan the lungs or the airway and do nerve blocks, but also not be afraid of these phased array probes. Because, this isn't your comprehensive exam. This is simple, goal-oriented, time-sensitive, and can, obviously be performed at the point of care. And sort of like the indications for this are, as we'll hear later, shock, cardiac arrest, pericardial infusion, or just an adjunct to the physical exam for, risk stratification. And so, in the data you get from FoCUS is not your, your detailed comprehensive echo report, but you do get an idea of, ventricular size, valvular abnormalities, volume, status of response, or any, growth signs of chronic heart disease like LVH. And so this is an article that's still in press, and so it's it has some, overlap and redundancies a lot of these articles have, but, in the two tables I put up from the article sort of show two things. Table 2 shows additional potential indications for hemodynamic instability, but so this is a very clean description in table 1 of what sort of like differentiates the basic exam TTE from a advanced to a comprehensive exam, which, anything but, 27 views and so on, it's on the right column that you can read, requires significant echocardiography training. But if you just look at the basic exam, it's 5 views, volume status, color Doppler, is even sort of like debatable, but whether you need that per se, but it shows you that clearly this is for all anesthesiologists and requires fairly basic training. Now, I would disagree the numbers of 25 exams versus I would probably double that number, and we'll come back to that in a little bit. But it clearly delineates that there is no quantitative assessments or Doppler and sort of a basic exam that we're going to discuss in today's lecture. So, and this is like this is where social media is so fantastic. This sort of like puts it all in one slide. Even cleaner is like, cardiac focus is is focused on specific protocols, not just the routine imaging to like at the bedside, but also different from critical care echocardiography because it is not detailed quite as detailed in terms of cardiography and fluid responsive to guide therapy. And also it nicely shows the difference between a limited echo and a comprehensive echo, where a comprehensive echo includes all the views, where a limited is like based as a follow-up exam. And the credit goes to FoCUS, who graciously allowed me to share the slide. So basic cardiac views, right? So we're not even going to look at all of the different colors on this view. The ones we're going to look at is your parasternal views, your subxiphoid views, and the apical four-chamber. With these views, and arguably because I am certainly biased to the FAPE protocol and a view of the pleura, you get all the information you need to save lives. The other views are nice to quantify things and helpful, but you can make significant, decisions with these views. So here, this is sort of a wonderful slide that delineates the different phased array probes. As it turns out, it often is the cheapest probe you can buy for your ultrasound machine that you hopefully have. So, let's get going. So the parasternal apologies if I muted myself. In the second to fourth intercostal space with the orientation marker to the right. And so here we have the image both and a schematic, a still image, and as in the still image rightfully is pointed out, it is not the right ventricle, but the right ventricular outflow tract, the left ventricle. You see nicely flapping your mitral valve leaflets, and you see your aortic valve coming into view. And sort of like it sort of shows you like the different things where you have a normal heart. It is pretty obvious that is a pericardial effusion in the top right corner. That is a severely enlarged right ventricle on the bottom left corner, and that there's a LV dilatation and failure, obviously, in the bottom right corner. So these are not subtle findings, and so while it takes about 50 exams or so to like see normal, well, I mean, these, if you see this, you have a pretty decent idea on what to do. So now if there we go. And then if you rotate 90 degrees with in the same position with the orientation marker now pointing to the right, you see the parasternal short axis view beautifully, and with like the left ventricle and a small right ventricle and the two papillary muscles, where this is also a view where you can sort of a little bit like a salami, sort of like scan your ventricle all the way from the apex up to the aortic valve. And again, our normal heart top left, pericardial effusion, the heart nicely bouncing around in there. Here, clearly, the D sign in the left ventricle and a grossly enlarged right ventricle here. well, in the bottom right corner, you see left ventricular dilatation and failure. That heart is beating, but not very well, particularly if it's not moving nicely together, particularly compared to the normal heart, and it is pretty obvious to the eye. And onto the subcostal view, where the probe is positioned under the sternum with the orientation marker to the right. As you see here, the grip is often different. Instead of the pencil grip, in this view, we hold the probe in sort of a screwdriver view, and often you have to slightly point a little bit, also like rotate about 10 degrees counterclockwise to get your optimal view. And what you get is this view, the where you see on top, because of your transhepatic insonation, you see the liver and so your right ventricle, because more superficial, obviously, to you know, and the right atrium, and then below the left ventricle, the left atrium. And again, you know, as Alberto Goffi always says, one view is no view. However, you know, when you see these views, I mean, you see there's a significant pericardial effusion around here again. RV dilatation that is, you know, not the worst I've seen, but you know, it is a significant, large, and collapse, not completely collapsing, but you know, giving the left ventricle certainly a run for its money, compared to here, where there is obviously this heart is not beating very well in the bottom right corner, and you see left the ventricle dilated, and the right ventricle not working really well, but you know, comparatively slightly better to the left ventricle. So there we go. And so and if when we was another a bonus view, so to speak, when we are in the subcyphoid view, is if we rotate the probe 90 degrees clockwise, we get an image of the IVC. Please make sure that you always see the connection to the right atrium, and also that you then scan to the left and find another vessel to the left, so you don't confuse this with the aorta. This is sort of topic for some debate. These numbers to a certain extent, but and what they signify, but if you have, you know, low CVP and you have a fully collapsing, then volume resuscitation fluid response is there, where if it is thick, plethoric, non-moving IVC, that signifies that, you know, the CVP is elevated, and further fluid therapy would not be helpful, and that it's time for some vasopressor support. And then on to the last view that we're going to cover today, the apical four-chamber view. Hold on, all right. Again, on the left we have, you know, top left we have a normal heart, you know, with the two ventricles up top and the atria below, where here again, you have your obvious pericardial effusion, and in the bottom left corner again, right ventricular dilatation and failure with the significantly enlarged right ventricle that is not a 2-to-1, but it's more like twice, with left ventricle being twice as big as the right ventricle, but more closer to being the other way. And then you see this clearly unhealthy heart with the left ventricle that's barely functioning, and severely reduced ejection fraction. And all right, so yeah, there is this article that we wrote, and when you publish in Rapam, you have to put these other things in there, but it's really focused cardiac ultrasound for any anesthesiologist. Also, in the article by Brett Cook and Josh Zimmerman that I mentioned, there is a simple way of doing a report, because to utilize the full utility of a focused exam and longitudinal value, in addition to ideally storing the images, a report would be significantly helpful, so that we can not have any ghost exams anymore, because otherwise it limits the utility in terms of patient care. So why does this matter? So risk stratification, we know, with moderate to severe aortic stenosis, the risk is higher, right? Significantly higher, depending on what your risk index is. So, if there was a way to look at this easily, and there is with FoCUS, why not do it? Because then you can optimize patients or get further studies if you need to. So pattern recognition rules sort of like supreme, right? Systolic murmur. So here is this great study by Cowie, where 5 anesthesia trainees got 1 hour of lecture on aortic stenosis and 1 hour hands-on training. And they were sent on their way to scan cardiac surgery patients, get these 3 views, and then report back on with their findings. And then the attending cardiac anesthesiologist also went to assess and examine the patient. And as it turns out, I think these are very bright trainees, which I'm sure they are. But it's when they see bad, it's not subtle. So when they see moderate or severe AS, and they were actually able to also measure peak velocity pretty well. So, and how long did that take? 5 to 9 minutes. I think that's a time investment that everybody would want to make in the care of their family. So 5 minutes are easily wasted on many other things. So I recommend to do that. And also, if that didn't sway you, if you have a point of care ultrasound service, there's that too. We'll come to that in a second. It is significantly better than with standard traditional assessment, whether it's cardiac, pulmonary, abdominal, or combined. You pick your organ system. It is in the 90s or 80s, and with a difference of at least about 55%, if not more, to 65%. So it may also save lives. That is a separate lecture. So I in the interest of time, we'll not go into more detail, but the ASA now said in 2015, when experienced operator is a reasonable alternative. Now, of course, you have to minimize interruptions of chest compression, so you probably have about 10, excuse me, 10 seconds to do this, but it certainly is something that's worthwhile. So training. So this is how our radiology colleagues sometimes see us, at least that's however, so there was a call to action, and that there should be training during residency. These fine gentlemen, they're based in the study for cardiac anesthesia, made these recommendations, but they thought should be included. And lo and behold, there already was a blueprint, because the year before, Dave Ramsing at that point in the UC Irvine had published this ultrasound training program for residents. I apologize. So the foresight is it's a pretty comprehensive thing. It was a 2-year program, and involves quite a bit of work with simulation, hands-on lectures. But it shows, it makes a big difference if it affects clinical management in 3 out of 4 patients and detects pathology in about 1 out of 3 patients. Then that is certainly something that's worthwhile to anybody's clinical care, and whether it's not limited to cardiac ultrasound. Another reason why it should be included. And lo and behold, this is just the inward-looking American way, or maybe it's been in the US too long, but it also made it to the board certification and to the residency training in terms of TT, ultrasound, vascular access, evaluation of standard views of the heart. So, then came this. This is a labor of love that's transcontinental, with the support of Sam Maroons, the current ASRA president, and the heart of the lungs of the project, Stephen Haskins. 2 parts to it. One, the clinical indications with the for airway, lung, gastric, fast, and FoCUS cardiac ultrasound, as well as thoughts to how to incorporate it into pediatric practice and handheld devices, and then also recommendations on how to achieve it and what numbers and how to go about things. So let's go into this for a little bit. So I'm not going to go over this whole document. It's certainly worthwhile reading. But so these are sort of like the must knows for regional anesthesiologists, right? We want to know where. It happens a lot rarer with ultrasound, but less still happens. We want to know if somebody has aortic stenosis and how bad their aortic stenosis is prior to considering your axial technique, if they had a hip fracture or your axial techniques in general. And we want to know if the patient is hypovolemic or if they need vasopressor support, if they're not. Or with joint surgeries come emboli. So in order to guide therapy, it would be helpful. So it includes the visual stimulating part, again, the freight cards, just because it may have some implicit training bias and mentoring biases that people have, but it is fairly compact and it fits on one side. There's also an app for that if you're interested in that. So, and then on to there's also recommendations. There was another ad hoc committee that I and Steve has been involved, but in this for the sake of consistency, and this is also consistent with the numbers that were in the Society for Critical Care Medicine recommendations and other studies. Well, we're not going to dwell on the other things. Level 1 studies that's worthwhile mentioning. They're personally performed, interpreted. That level 2 studies are interpreted but not performed. So it does take. It is the steepest learning curve compared to lung ultrasound, airway ultrasound. But it's certainly a worthwhile investment and to make because of the profound effect it has. So, and so like this is sort of like in part 2, right? So like this is the IAM framework with indications, why, how, what to do with it, and what to do with what you see, and then the decision-making part. It's there is more sort of a table for all the major organ system covered, but these are sort of like the items we feel the expert group felt that people need to know. So limitations and conclusions. Wait, ultrasound has limitations. Isn't this like the wrong group of people to talk to? So again, in part 2, barriers, right? These are sort of our attempts. It's like helping with the most common things that people run into: lack of equipment, the handheld devices. Well, the imaging quality is not to the liking of a lot of the people lecturing today in the audience. They're a lot more affordable, and so the democratization of ultrasound is being achieved more and more with them. Lack of curricula. There is websites. There's 4 sites. Use ABCD. There is and many other locations, and then sort of like it comes down to lack of sufficient qualified faculty. Now that is sort of a lecture in itself, and ideally, you have a sort of 3-pronged attack on, in a training program with training the residents, the faculty, and as well as the fellows. But not everybody has the resources. So talk to people. Like if you have you may be the local champion, but sonographers and cardiologists and radiologists are quite happy to lend their expertise and find out more why you are interested in it. And with the pandemic, the reverse classroom has become the bane of our existence. But I mean, between that and social media, near peer and FoCUS education, has sort of been able to flourish despite all the lockdowns and limitations that we have to education these days. So limitations with FoCUS. It's purely qualitative. It's not for the detail. It's like for the big ones. It's for the obvious stuff. FoCUS, yeah, it's more difficult to learn than other FoCUS skills, but it is worthwhile. And all of the speakers on the faculty, they can give you examples where they have saved the life with FoCUS and with FoCUS. Right. If you have a question, call an expert. If it doesn't feel right, call for help. Don't make any decision if you're not sure. It is a journey, and there is a learning curve, and persistence pays off. Once you explain to your cardiologist what you're actually doing, then they realize that potentially you may be supplying them more patients through your pre-op clinic than taking their comprehensive TTEs away. And this is so crucial. Put it into clinical context. Don't treat the image, treat the patient. So, another thing, and the conflict of interest that I mentioned is the American Society for Anesthesiology now has a FoCUS certificate that allows you to gain more education, potentially to show competency to your local credentialing committee, and it also has a pretty neat educational platform, and allows you sort of to get so a little bit more of a formal thing. Now I know in the UK they have FoCUS and BSE, so this is not compared, but this is in the United States the only sort of FoCUS certificate, not a certification. So it's an educational certificate that is available to all physicians, primary to geared at anesthesiologists, but to all physicians. So I'm happy to answer offline more questions about it. Currently, it includes airway, lung, gastric, and cardiac, with fast questions being finalized as we speak. And so usually I make this FoCUS, but for today's talk I make it FoCUS. So hopefully I was able to show FoCUS is a helpful additional tool. It's fast, mobile, even more so with a handheld device. It's obviously not invasive. It's real time. It's useful to answer. It's as simple, but concise, focused clinical questions. It's relatively easy to learn. Not as easy maybe as some of them, but it is not that hard. It takes there's a steep learning curve, but it's it will become more commonplace, hopefully. And the question is, when will it become the standard of care? So, or should we do FoCUS with every physical exam? So, so with that, so I want to invite you to visit us when you can. Again, either in beautiful California right now. It's a little darker than that, not even quite as light as this, our shiny new hospital, or join us in Las Vegas, or at one of the upcoming ultrasound courses that ASRA Pain Medicine, as the new name is, as of a couple of weeks ago, puts on and come with our partners from USABCD.